Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Preoperative Chemotherapy plus Trastuzumab, Lapatinib, or Both in HER2-positive operable breast cancer. Results of the randomized Phase 2 CHER-LOB study by Valentina Guarnieri et al. My name is Harold Burstein, and I'm a breast cancer specialist at the Dana-Farber Cancer Institute in Boston, recording a JCO podcast entitled 1 + 1 = 3, the combined use of anti-HER2 agents in the neoadjuvant setting. Neoadjuvant therapy is the darling of breast cancer investigators because it affords a short-term readout on the likely potency of novel treatment strategies. Patients with HER2-positive tumors, in particular, have been a common population for clinical investigation of neoadjuvant treatments, owing in part to the availability of novel anti-HER2 drugs and the proven efficacy of adding trastuzumab to chemotherapy in both the adjuvant and neoadjuvant settings. Laboratory studies have suggested clinical synergy between the two commercially available anti-HER2 agents, trastuzumab and lapatinib, and the CHER-LOB trial was one of several designed to test whether that synergy could be captured in the neoadjuvant treatment of HER2-positive breast cancer. Patients in the CHER-LOB study had stage 2 or 3 breast cancer with HER2-positive tumors. They were randomized to receive chemotherapy plus trastuzumab, chemotherapy plus lapatinib, or chemotherapy plus trastuzumab and lapatinib, the combination of the two. The preoperative chemotherapy backbone consisted of single-agent paclitaxel for 12 weeks, followed by 4 cycles of FEC chemotherapy, that's fluorouracil, epirubicin, and cyclophosphamide. The primary study endpoint was pathological complete response. There were a variety of secondary endpoints based on tumor response and safety. A total of 121 patients participated in the study. The CHER-LOB study found a pathological complete response rate of 25% for chemotherapy and trastuzumab, 26% for chemotherapy plus lapatinib, and 47% for the combination of chemotherapy with both anti-HER2 agents, lapatinib and trastuzumab. Thus, dual-targeted HER2 therapy nearly doubled the rate of complete pathologic response. All told, nearly 90% of patients had a clinical response to treatment. There were comparable rates of breast-conserving surgery or conversion from mastectomy to breast-conserving surgery among the 3 cohorts of patients. The treatments were reasonably well tolerated, though the majority of patients offered lapatinib required dose reduction, and roughly 25% of patients in the lapatinib arms discontinued lapatinib treatment. There were no signals of cardiotoxicity. The CHER-LOB study is one of 3 trials that have reported results comparing preoperative chemotherapy with trastuzumab, lapatinib, or both as a neoadjuvant treatment for HER2-positive breast cancer. The other trials were the NeoAlto study, which used paclitaxel monotherapy as the chemotherapy backbone, and the second study, this one from US Oncology Network, which used FEC followed by paclitaxel as the chemotherapy backbone. The important finding, shared by all 3 of the reported studies, is that chemotherapy used in combination with the dual-targeted anti-HER2 approach of trastuzumab and lapatinib consistently improved pathologic complete response rates compared to single-agent anti-HER2 therapy. In none of the trials was the chemotherapy lapatinib arm outperformed by the chemotherapy trastuzumab arm. Based on that let me clarify that. In none of the trials did the chemotherapy lapatinib arm outperform the chemotherapy trastuzumab arm. And based on that observation, the design of a 4th and related trial, CLGB 40601, has been modified. CLGB 40601 compared preoperative use of chemotherapy with trastuzumab, lapatinib, or both, and because of the available data, has now closed accrual to the chemotherapy lapatinib arm. In all reported studies to date of neoadjuvant chemotherapy, pathologic complete response rates are higher in ER-negative than in ER-positive tumors. The CHER-LOB, Neoadjuvant, and U.S. oncology trials all showed higher PCR rates for anti-HER2-based therapies, again, in ER-negative than in ER-positive tumors. This basic observation suggests the potential for clinically important synergy by using two anti-HER2 agents at once. In essence, 1 + 1 is 3 when it comes to activity with anti-HER2 targeted biological therapies. This result, or suggestion of 1 + 1 is 3, is also supported by recent data from studies pairing trastuzumab with a different anti-HER2 antibody, pertuzumab. In both the Cleopatra study of chemotherapy and trastuzumab with or without pertuzumab for metastatic breast cancer, and the Neosphere study, a study of neoadjuvant treatment using chemotherapy and trastuzumab, again with or without pertuzumab for HER2-positive earlier stage breast cancer, the results were better with the dual-targeted approach. Clearly, pushing hard into the HER2 signaling pathway has dramatic results. And it makes one wonder, would giving 3 or even 4 anti-HER2 drugs all at once be still more effective? Notwithstanding this apparent synergy between HER2 agents, a basic clinical question remains: what do these results from neoadjuvant therapy, based on a relatively small number of patients without long-term follow-up, mean for standard treatment of HER2-positive breast cancer? And in particular, should chemotherapy trastuzumab lapatinib, a cocktail shown to have superior upfront activity now in 3 randomized trials, be a regular treatment option for women in the neoadjuvant or adjuvant setting? The practical dilemma here is that it is unclear what the stepwise improvement in rates of complete pathologic response, defined within the first several months of treatment, would mean for long-term rates of tumor recurrence in women who would also be receiving adjuvant trastuzumab, and who, in many instances, might also be receiving adjuvant endocrine therapy. For that reason, the answer to our basic clinical question remains no. Outside of clinical studies, we are not routinely offering lapatinib in addition to chemotherapy and trastuzumab for early-stage breast cancer. The ALTO trial, an adjuvant study with a similar scheme as the Neoadjuvant study, that is, comparing chemotherapy with trastuzumab, lapatinib, or both, will be the study that may provide confirmation in the adjuvant setting for the neoadjuvant principles of synergy that have been seen with the dual anti-HER2 combination regimens. However, the ALTO results are not as yet available. In addition, the long-term use of lapatinib as adjuvant treatment may yet prove difficult or different from in its efficacy or tolerability than the shorter courses of therapy employed in the neoadjuvant exposure setting. Recent FDA statements have suggested that novel endpoints, including rates of complete pathologic response, might be used for new drug approval. The CHER-LOB data and results similar to it highlight the potential opportunities and the potential pitfalls of that approach. Because near-term endpoints are defined, and because all patients are informative for data, neoadjuvant therapy offers the potential for smaller studies and quicker results. But the relationship between changes in rates of complete pathologic response and changes in long-term disease outcomes, and the discordance between the way the drugs might be given in the neoadjuvant setting and the way they might be used in the adjuvant setting, imply potential limits on how much might currently be inferred from neoadjuvant studies that can or should be directly related to changes in clinical practice. Neoadjuvant treatment in CHER-LOB, an important randomized trial, has shown the potential for multiplexing anti-HER2 treatments. One hopes they presage progress in long-term outcomes for women with HER2-positive tumors. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.